Interactive case, hypoxic pulmonary vasoconstriction, HPV in action. A breathless mystery. Dr. Carter, a pulmonology resident, is working a night shift in the PICU when a 15-year-old man named Mr. Williams is admitted with severe shortness of breath. He has a history of obstructive sleep apnea, OSA. The patient was found cyanotic and confused at home after falling asleep without his CPAP machine. His arterial blood gas, ABG, reveals PaO2, 50 mmHg, PaCO2, 60 mmHg, pH, 7.28. Why does this patient have such severe hypoxemia despite his lungs still getting blood flow? Let's dive into hypoxic pulmonary vasoconstriction, HPV, and its role in this case. Question 1. What is the primary function of hypoxic pulmonary vasoconstriction, HPV? A. To constrict systemic arterioles in response to hypoxia. B. To divert blood flow away from poorly ventilated alveoli. C. To increase alveolar oxygen levels. D. To increase pulmonary blood flow when oxygen levels are low. Correct answer. B. To divert blood flow away from poorly ventilated alveoli. HPV is a localized pulmonary response where pulmonary arterioles constrict in response to low alveolar PO2, PaO2. This redirects blood flow to better ventilated lung areas, optimizing gas exchange. Unlike systemic vessels, which dilate in response to hypoxia, pulmonary vessels constrict to minimize ventilation perfusion, VQ mismatch. In Mr. Williams' case, HPV is activated due to his low alveolar oxygen levels from hypoventilation and underlying lung disease. However, prolonged or widespread HPV can contribute to pulmonary hypertension and worsening hypoxia. Question 2. Which cellular mechanism underlies HPV? A. Activation of beta-adrenergic receptors in the pulmonary arteries. B. Increased nitric oxide, NO, production leading to vasodilation. C. Hypoxia-induced inhibition of potassium, K+, channels, leading to smooth muscle contraction. D. Decreased intracellular calcium, Ca2+, levels causing vasodilation. Correct answer. C. Hypoxia-induced inhibition of potassium, K+C, channels leading to smooth muscle contraction. In pulmonary artery smooth muscle cells, low oxygen levels inhibit O2-sensitive potassium, Kk+C channels, leading to membrane depolarization. This triggers opening of voltage-dependent calcium, Ca2+C channels, calcium influx, which activates smooth muscle contraction, pulmonary arterial vasoconstriction. This response helps shunt blood away from hypoxic regions, ensuring better oxygenation in ventilated alveoli. However, chronic hypoxia, sleep apnea, leads to persistent HPV, increasing pulmonary vascular resistance and potentially causing pulmonary hypertension and right heart strain, cor pulmonale. Question 3. How does inhaled nitric oxide, NO, affect HPV? A. Enhances hypoxic vasoconstriction. B. Reduces HPV by increasing cGMP levels in pulmonary vessels. C. Inhibits Ca2+ influx into smooth muscle cells. D. Both B and C. Correct answer. D. Both B and C. Inhaled NO 20 ppm can reduce HPV by stimulating cGMP production, which promotes vasodilation, inhibiting calcium entry, preventing smooth muscle contraction. In clinical settings, inhaled NO is used to treat pulmonary hypertension and hypoxemic respiratory failure by selectively vasodilating pulmonary vessels without affecting systemic blood pressure. In Mr. Williams' case, HPV is exaggerated due to chronic hypoxia, and prolonged vasoconstriction could worsen his respiratory distress. Final question. What would be the best immediate management for Mr. Williams? A. Intubation and mechanical ventilation. B. Supplemental oxygen and non-invasive ventilation. BiPAP. C. Inhaled nitric oxide. No echo. Therapy. D. IV fluids and diuretics. Correct answer. B. Supplemental oxygen and non-invasive ventilation. BiPAP. BiPAP helps correct hypoventilation by improving CO2 clearance and alveolar oxygenation. Supplemental oxygen raises PaO2, reducing HPV and pulmonary vasoconstriction. Avoiding intubation is preferable unless the patient worsens. Inhaled. MO is not first line unless pulmonary hypertension is severe. IV fluids should be used cautiously, as fluid overload can worsen pulmonary edema. Conclusion. Lessons from Mr. Williams' case. HPV helps optimize oxygenation by diverting blood from poorly ventilated alveoli. Chronic HPV, seen in COPD, OSA, and high-altitude exposure, can contribute to pulmonary hypertension. Oxygen therapy helps reverse HPV while inhaled. No selectively vasodilates pulmonary vessels in severe cases. Mr. Williams improves within hours of BiPAP and oxygen therapy, avoiding intubation.